Good evening. We'd like to welcome everyone to the Parathyroid Awareness Month webinar hosted by the American Association of Endocrine Surgeons. I am Masha Livhits. I'm an endocrine surgeon at UCLA and the chair of the Patient Advocacy Committee, and I'm one of tonight's moderators.
Hi, I'm Benzon Dy from Mayo Clinic, and I'm also an endocrine surgeon, and I'm the other moderator for tonight's webinar. We have assembled an expert panel to answer your questions about primary and secondary hyperparathyroidism. Tonight's webinar is being recorded and will be available on the AAES Facebook page and on the AAES YouTube channel in the next several days. We would like to thank the Paratrooper Patient Group for providing us with frequently asked questions from their membership. We will also be taking live questions from the audience this evening. You can enter your questions in the comment section directly on the Facebook live stream. Please be aware that we will not be answering any personal medical questions or providing specific medical advice. For those types of questions or requests, please seek advice from your doctor or medical team.
We'll start by introducing and getting to know our panelists in alphabetical order. Let's start with Dr. Sophie Dream. Please tell us a little bit about yourself.
Hi, I'm Sophie Dream. I'm an endocrine surgeon at the Medical College of Wisconsin. I did my fellowship training at UAB and I have a focus in parathyroid disease and quality of life outcomes for my research focus.
Dr. Brenessa Lindeman.
Good evening, everyone. I am truly pleased to be with you. I am an endocrine surgeon at the University of Alabama at Birmingham, where I have the privilege of serving as the section chief of endocrine surgery and also director of our fellowship program. It's especially great to be here with Sophie. And then I also serve as our associate dean for graduate medical education.
Dr. Stuart Sprague.
Good evening. It's also a pleasure for me. I'm Dr. Stuart Sprague. I'm a nephrologist who specializes in bone and mineral metabolism and parathyroid disease. I'm the faculty at the University of Chicago, and I'm the head of the bone and mineral and nephrology division at Northshore University Health System, part of the University of Chicago.
And Dr. Robert Wermers.
Yeah, hi, Rob Wermers. I'm with the Mayo Clinic, Rochester. I'm an endocrinologist specializing in metabolic bone disease, and I've had a long-standing interest in primary hyperparathyroidism.
Great, thank you to our panelists for joining us. We will begin tonight's webinar with a short presentation of the upcoming AAES guidelines on secondary hyperparathyroidism from Dr. Dream and Dr. Lindeman.
Thank you so much, Benzon. Everyone, give me just a moment to share my screen. And I will ask that if you can't see my slides, if someone lets me know, otherwise I'll assume they're there. And I thought Sophie and I spoke and thought it would be useful to provide a little bit of an overview about what everyone should know about secondary hyperparathyroidism. And she'll dive a little bit more into the guidelines, as really she was one of the foremost leaders for the guidelines, and I just had a privilege of taking part. So in the normal state, as you all are very familiar, calcium and PTH, which is represented graphically by this thyroid and the little highlighted parathyroid glands, exist in a balance that should be most like a seesaw, that when the calcium is low, PTH is secreted, and that helps to raise the calcium. And in the normal state, the PTH should go back down. So there should be this seesaw-like motion. However, in secondary hyperparathyroidism, there is typically something that is causing the body to not receive enough calcium or to lose excess calcium. And so in this case, that low calcium triggers an increase in PTH, and sometimes it's an incredible increase in PTH, as Sophie will likely describe. And so that's contrasted with the condition that you all may be most familiar with. Oh, I'm sorry, let me back up and say the three main causes of secondary hyperparathyroidism are vitamin D deficiency, chronic kidney disease, and malabsorption, where you're not able to absorb calcium from the GI tract. And so this state is contrasted with what you may be more familiar with in primary hyperparathyroidism, where there is an increase in PTH, parathyroid hormone, from one or more parathyroid glands that has in effect gone rogue and is making continuous hormone irrespective of the calcium level. And so that drives the calcium level up as well. And so I wanted us to consider how common secondary hyperparathyroidism is. Vitamin D deficiency is the single most common cause. I can just raise my hand and say, I am vitamin D deficient and on supplementation. And I'm in good company because approximately 40% of us in the United States are vitamin D deficient, at least to some degree. And it takes more severe vitamin D deficiency to start seeing a measurable effect on PTH, but it is something that we see in our patient population because we're following track very closely. Another common cause is kidney disease, as I alluded to, and the degree of hyperparathyroidism really depends on the stage of chronic kidney disease, or CKD, that the person is in. And it is near universal by the time someone gets to dialysis, but we see that it increases over time, that the worse your renal function is, the more likely that you are to have secondary hyperparathyroidism, the higher that your PTH will be. And the malabsorptive causes, the most common is in patients that have had a gastric bypass procedure. And if you compare the types of weight loss operations that someone can have, the Roux-en-Y gastric bypass tends to, of the common ones performed now, tends to cause the highest degree of vitamin D deficiency from malabsorption of calcium, and that can lead to secondary hyperparathyroidism. And so there are 45,000 of these operations performed in the United States each year. And one study that's cited below shows that 33% of patients had secondary hyperparathyroidism at the 1-year mark, and it was around 60% at the 5-year mark. So it's definitely something that can be common. And so how do we treat it? Well, vitamin D deficiency is easily treated with medication. I can certainly personally attest to that. For CKD, the ideal treatment is kidney transplantation. And then for gastric bypass or other malabsorptive causes, we tend to lean also on medication and supplementation to try to decrease the malabsorptive effects. And so as we think about differentiating secondary hyperpara from primary hyperpara, we can lean on these sort of nomograms. I think that's one of the questions that was submitted in advance. And really this area where the calcium is normal to low, but the PTH is high, that's this group of individuals that have secondary hyperparathyroidism. And this is just a slightly different view of this, thinking about, the different causes of primary and secondary, and then also including the hypoparathyroid group. So if we think about, again, how to differentiate, we're not so concerned with kidney disease because those patients predominantly only have secondary hyperpara. So in the vitamin D deficiency group, we tend to treat that with medication, and typically the PTH goes down following that. And so if it is secondary hyperparathyroidism, we see that following administration of vitamin D, that the calcium will tend to normalize if it was low. But then in the primary hyperparathyroidism setting, we see this a lot in our primary hyperpara patients because so many people are vitamin D deficient, that someone may have a calcium that's on the upper end of the normal range, and we're not quite sure, is this secondary, is this primary, and they're vitamin D deficient. So we replete their vitamin D, and most of the time in primary hyperparathyroidism, the calcium will actually rise then because your body is able to absorb it more efficiently. In the gastric bypass population, their PTH levels are elevated because they're not absorbing calcium as well, and they're not able to absorb vitamin D as well. And so in those patients, the calcium may be normal, it may be low, but we also replete those patients with vitamin D, sometimes with calcium. And typically in that patient population, we'll see that the PTH goes down, but But if they truly have primary hyperparathyroidism superimposed upon that, their calcium may rise following vitamin D administration. And so there are some specific concerns about parathyroid surgery in patients with non-renal secondary hyperparathyroidism. So in patients that have vitamin D deficiency and undergo surgery, maybe they were very symptomatic or had reasons they couldn't wait to replete, then we've decreased their parathyroid tissue volume, and their bones now that have been stripped of calcium say, oh, give me back all of your calcium. And so we can term them hungry bones. And so those patients often need both vitamin D and calcium in the postoperative setting. And in the gastric bypass patients that end up having surgery, we take a little bit of a more cautious stance that we all have 4 parathyroid glands predominantly, and that some studies recommend that we just take out 3, and we want to leave more than a typical normal parathyroid remnant, because these patients can suffer from pretty severe hypocalcemia and also tend to need both vitamin D and calcium in the postoperative setting. So with that, I will stop, and I look forward to answering questions later on in the panel. Thank you so much.
Sorry, just give me a second to get my slides up. Thanks so much for that, Brenessa. I think it really sets up it's for us to talk a little bit about secondary, tertiary hyperparathyroidism. So I'm going to go a little bit over the definition of what we're expecting to when we see these hyperparathyroidism in the setting of kidney disease, and when we really consider operating. So for secondary hyperparathyroidism, in the kidney setting, like Brenessa was talking about, it's really from some underlying cause. So when we look at it for kidney-related disease, it's really highlighted by having a low calcium, a high phosphorus, low vitamin D levels, and then high parathyroid hormone levels. In the setting of end-stage kidney disease or progressed kidney disease, parathyroid hormone levels, when we talk about normal levels, we really want to see them to be higher than normal. So 2 to 9 times the upper limit of normal. So for a lot of people, that's falling in the 300 to 600 range. And that's important because having a high parathyroid hormone level in the setting of kidney disease can actually have some benefits. So it does help maintain some bone health, and there's a lot of studies that show that. So when we are approaching parathyroidectomy in this setting, or to decide when to do it and what our goal PTH is after surgery, that goal might not be in the normal range depending on where we are at with kidney disease, and if we're talking about doing kidney transplant, and if you've already had a kidney transplant. So it's just really important. As parathyroid disease and kidney disease progress, then that elevated PTH slowly increases, and it can have an impact on your kidney and heart health, and then have some impacts on quality of life in terms of having like itchiness, weakness, and then some cognitive decline as well. So
Sophie,
really
I'm so sorry, but your main slide isn't changing.
Oh, it isn't?
No.
Oh.
It just looked like you weren't in slideshow mode, like the presenter view.
Let me see if this works. Is that?
Yes.
Okay.
Yes, I see it now.
All right. So it's really important first line treatment for secondary hyperparathyroidism. It's very multidisciplinary and very driven by our nephrologist as well. So medical management and optimization is really key here. So the goals being lowering parathyroid hormone level, lowering calcium and phosphorus, and then increasing vitamin D levels. So we really kind of rely on our nephrologists to be able to help out with this, and then to help kind of signal when we need to be talking about parathyroid surgery. So when we consider parathyroid surgery, it's really to reduce cardiovascular and all-cause mortality. That's the one thing we know we can help here. We consider it in patients that have secondary hyperparathyroidism where medical therapy is really not quite cutting it. So you have PTH levels that are higher than the 9 times the upper limit of normal, and then any one of these indications here. So uncontrolled high calcium or phosphorus, non-bony calcium deposits, so within the soft tissue, bone fractures, weakness of the muscles, bone, or joint pain that's causing effect on quality of life. Itchy skin that's causing skin changes or affecting quality of life, and then high calcium in the setting of of pending kidney transplant. So someone that's ready to get a kidney. Tertiary hyperparathyroidism is a little bit of a different entity. So this is when the parathyroid glands are not reacting to the calcium being low. So the parathyroid function is acting regardless of what the calcium level is in your bloodstream. So we see this a lot in patients that have been on dialysis for a very long time, or who have already gotten a kidney transplant. In the setting of someone who's already gotten a kidney transplant, we really are defining it as someone who has high PTH for 6 months after kidney transplantation. And in tertiary hyperparathyroidism, it often can look like primary hyperparathyroidism, where the calcium level is high and the PTH levels are high, but you can also have normal calcium levels. So it's a little bit tough to decide in the normal calcium setting when patients should have surgery. So for tertiary hyperparathyroidism, once we have made that decision that it's probably not going to resolve despite kidney transplantation, then we say parathyroid surgery is the best management there. So people who have been on long-term dialysis or post-kidney transplant, and then we're really recommending that people start to talk about having surgery somewhere in that 12-month window after having a kidney transplant, because we know we want you to get in and be seen and taken care of before you're hitting that 12-month window, because from then on, it can have some negative impacts on your kidney health. So it's really important.
Wonderful. Thank you both so much for that update. We're really fortunate to have you both here with us and giving us an update on secondary hyperparathyroidism. We're going to go to our Q&A live portion now. And for anybody who's watching, feel free to post your questions into Facebook, and we'll go ahead and answer them in real time. The first question that I would like to first direct to Rob would be, we've had several questions come in about FHH. You know, what is FHH? What is the overlap between FHH and hyperparathyroidism? How can you know which one you have? Is it possible to have both?
Yeah, so FHH appears biochemically exactly like primary hyperparathyroidism often. There are some nuances where you may see higher calciums in FHH. About 75% of patients with FHH actually have a normal or high normal PTH. 25% will have elevated. So, but a lot of times it can look exactly like that, and it can be difficult to distinguish the two. And FHH is due to a mutation in the calcium sensing receptor in the parathyroids as well as the kidneys. And unfortunately, even if you remove 3.5 parathyroid glands, you're going to continue to have hypercalcemia, which is a distinguishing feature in these patients. Whereas if you have other causes of multiple gland disease, like MEN1, multiple endocrine neoplasia type 1, or Wermers syndrome, but not named after me, you will actually normalize, or the calcium will normalize in those patients when you do the 3 or 3.5 gland procedure. Now, there are some clues when I think about FHH versus primary hyperparathyroidism. Family history is really important because this is a very strongly inherited disorder. It's autosomal dominant, meaning half of your offspring will get this. You'll have calcium that's lifelong. So if I see somebody who's had calcium since a young age and it's never been normal, that would be a clue for sure. If somebody had a normal calcium, 9.2, 9.3, and then after menopause, it's high, that isn't going to be FHH, for example, and that's another clue. Persistence after the surgeons operate on them. If they have persistent disease, I think about FHH. And age is important. If they're young, I always think about FHH. So if they're in their 30s or 20s, for sure, I'll think about FHH. And what's becoming inherently clear is, based on some recent data, the disease is much more prevalent than we previously had thought, and that's data out of Europe. So we don't want to operate on FHH in general, because most patients do not have any associated complications. I'll just go over one hallmark feature. I don't want to say too much if there's other questions, but one of the hallmark features we do in somebody where we want to try to screen for that, we'll do a 24-hour urine study to look at calcium in the urine, and we also do a creatinine, and we can measure excretion of calcium in the urine, and patients with FHH typically will have a low urine calcium, but unfortunately, there's a lot of overlap and it's not perfect. So again, if I have somebody, where they have a lot of the other clinical features, I may consider genetic testing. It's important to remember that only 70% of patients with FHH will have a positive mutation that we find. 30% have the disease, but mutation testing can be negative. So that's kind of a nutshell. I don't want to keep going on forever.
No, that was great. That was really helpful. Thank you. Stuart, do you have anything that you'd like to add? And also in particular, I think some patients, if they've been diagnosed with FHH, it's hard for them, why is it okay for them to just live with this high calcium? Is it not affecting their kidneys or something else?
Yeah, no, I agree with Dr. Wermers a lot. I think the key, the way I look at it, is you really got to do a 24-hour urine. Again, it's not 100%, but if someone's excreting, less than 80 milligrams or so of calcium in a 24-hour period, that's really suggestive of FHH. As he mentioned, there's a mutation in the calcium sensing receptor. So in fact, you actually need a higher serum calcium in order to appropriately respond, for that receptor to appropriately respond both in the parathyroid gland and in the kidney. So making the calcium normal is actually pathologic in this patient population. The other caveat, which is sometimes a problem when patients are sent to me as a nephrologist, is that if they have even mild to moderate kidney disease, the urinary calcium plummets. So it becomes very difficult to say that the urinary calcium is low because of FHH, or is it low because of their chronic kidney disease. So that's a real caveat. Again, we tend to like to do genetics testing in those patients, but again, as he mentioned, at least 20 or 30% of the patients, you will get a false negative.
And Brenessa, have you had any patients with both FHH and hyperparathyroidism? And have you operated on any of those?
I have to tell you, to date, I've not had any patients with coexistent true primary hyperpara and FHH. I have diagnosed 2 patients with FHH that were sent to me thinking that it was hyperparathyroidism alone. And I agree with what my colleagues have been saying, that it tends to be a little milder disease, long-standing, and the 24-hour urine was really the most helpful piece of information in trying to clinch that diagnosis. And then we refer those patients on for genetic testing, which has really been the confirmatory test.
So fairly rare for there to be a coexistence. Anybody in the panel who's managed a patient with both hyperparathyroidism and FHH?
Well, the only thing I would say is these patients get hyperplastic glands. Their glands can get big. And so it can look like, when the surgeons go in, they can have big glands when they're removed. So they're, in a way, you do get kind of a pseudo hypo. I don't know. You can get big glands in that disease. There's no doubt about it.
Let's move on to our next question then. I think this is a great one for everyone on the panel, and I would say that we've probably all had this questions, but for patients who have had parathyroidectomy and they've had a high calcium, but it's now normal, and we define cure as normal calcium at 6 months, but PTH is still mildly elevated at that point, what should the patient do? Why is it okay to just monitor the situation at that point?
I'm happy to take a stab at it if that's okay to start with.
Yeah, I think we see a lot of this together, Rob.
Yeah. Well, there's some data that's been recently published, and I think what we're finding out is that if you check both PTH and calcium, that a significant number of patients will either have a high calcium with a normal PTH, a high PTH with a normal calcium, about 12.5% in each of those arms based on a Michigan study. And then about the other 2, whatever it is that's left over, 2.5% will have persistent disease, meaning high calcium and high PTH. Now, we've defined recurrence in the surgical literature or persistence based on calcium, not PTH. And that's kind of the conundrum is when you look at that, we almost don't want to check a PTH because we're scared what we're going to find, probably, to be a little bit honest, because it gets to be a problem to know what to do. I think what's interesting is that some of the data that's out there suggests that actually your risk of recurrence is higher in the long run if you have a high PTH with a normal calcium than vice versa on that. So I think we have a lot to learn. There's a lot of unknowns on how to manage this and what to do. Should we be checking PTH and calcium? But I'd be open. I think I'd be interested to hear other thoughts on this because we don't know a lot about it.
I would tend to agree with what you said. I think it's very difficult, and what we tend to look at it to see. We talked earlier about a low urinary calcium. Sometimes I'll further evaluate them and measure urinary calcium, and if it's significantly high, then I'd be even more concerned that there might be persistent disease and we may have to go after it. But again, as you said, there's not a lot of good, clear data in how to progress. But I tend to look to see what both the calcium and the abnormal kidney function, the phosphate is, because if the phosphorus is tending to run low and the urinary phosphorus is tending to be a little bit high, to me that's inappropriate, and we have persistent disease. And I tend to follow that type of patient very closely. I don't run to send them back to surgery, but do follow them very closely. My personal experience is that surgery, I'm not being a surgeon, but working with some very good ones, surgery sometimes is very difficult to go back in after these patients.
Yeah, you read my mind about that when you were saying, don't run and have them go back to surgery. I mean, I don't think there's anyone that thinks running to go back to surgery is the best option. And I am also in agreement with what you said, that there are no great data to support exactly what we do in these situations. It's been my experience in practice. So this is anecdotal. This is not science, but it's been my experience in practice that the time frame in which this is measured is important. That we see our patients back 2 weeks after surgery and check their labs at that time point. And there are a fair number of patients whose calcium has normalized, but or even is on a little bit the lower end of normal, but their PTH is just above the higher end of the reference range. And then we follow them further out. We may check their labs again in a few weeks. We always check their labs at the 6-month mark to confirm cure. And typically that resolves. And so I think that there's some interplay. This is my hypothesis. There's some interplay with the calcium sensing receptor, that it sort of has to go back to a normal setting and normal homeostasis, that their bodies are used to seeing higher calcium. And so the remnant parathyroid gland or glands is reacting to that and secreting a little bit of excess PTH. So as frustrating as it is to see those lab values, I encourage my patients to be patient, for lack of a better word, and we can just wait it out and give it some time to see what happens. And often it resolves.
I'd like to
Sophie?
just
Go
interject.
ahead.
I'm sorry, you bring up a good point, and again, I don't want to get too complicated or scientific here, but we do know that as we develop these nodules, the hyperparathyroidism, we lose calcium sensing receptors. So we get downregulation and they actually disappear. And it may be that it takes time for that to normalize afterwards. I don't know of any good studies that have looked at that, but if you have multi-gland hyperplasia or nodules, we know that the calcium sensing receptor has been decreased and downregulated. So that could play a role in there too, in terms of from a scientific perspective. So it does make sense.
Sophie, do you think in some of these patients that we're curing with hyperpara and persistent elevated PTH but normal calcium, are we unmasking secondary hyperparathyroidism in some of these patients?
I think that is important to think about. And your GFR is an indication for parathyroidectomy in the setting of primary hyperparathyroidism. So I do think it's important to take a look at what could be an underlying cause and if the kidney is playing into it. And in that case, you might want the PTH to be a little bit higher. But yeah, again, looking at like the vitamin D and making sure that the vitamin D is not a contributing factor to, and like really all causes of secondary. I think it's important.
So, we were just talking about what happens when the parathyroid hormone levels remains a little bit elevated after the surgery, even if the calcium normalizes. But let's talk about quality of life, which I think is a primary concern for a lot of our patients. So what happens if they have a successful parathyroidectomy and the levels seem like they normalize, but there are persistent quality of life symptoms? Pain or this kind of brain fog, fatigue, that kind of thing. So Sophie, we'll stay with you. What are your thoughts about that? Do you think it's still connected maybe from years of untreated hyperparathyroidism? Is one of our patients is asking.
Yeah, so I think so I just did a systematic review of like a lot of these quality of life surveys. And the thing that we found is most of the surveys will show that like fatigue and like mental fog and confusion, those neurocognitive symptoms can get better after surgery. So patients will report some sustained improvement even a year after surgery. Joint pain a little bit, not so much. And there's like a long list of things that can get better, but we're not 100% certain. I think the thing that's important is that like some of these changes can improve, but are not always going to be comparative to like someone who's never had hyperparathyroidism. And it's hard to say if that is because of you've had hyperparathyroidism and it's never going to go back to completely where you were before having it, or if there's just something that was there and the hyperparathyroidism made it worse. And then you kind of go back to your baseline. So it's really hard to say if it's ever going to get better. But I think we usually see those changes usually within that first 1 to 2 months. And if you see those changes, they're going to be lasting is what we know.
Brenessa, what do you see in your patients who have had parathyroidectomy in terms of quality of life?
Yeah, I think there are some really good studies that have been done that describe the likelihood of specific symptoms to improve. And most of the time symptoms improve over, as Sophie said, within the first 1 to 2 months. There are some that linger and we can see some improvement up to the 6-month mark. So I tell people not to be discouraged when they come back at 2 weeks and they still have a few symptoms. And the ones that are most likely to be improved are things like fatigue, mood changes, brain fog, difficulty with short-term memory, and then the muscle, bone, joint pains. Those tend to really improve. But I often tell my patients that the list of symptoms that can be due to parathyroid disease is very long. And the challenge is that none of them are unique to parathyroid disease. They can all be caused by something else. And so whatever component of a symptom is due to parathyroid disease, that typically gets better after parathyroidectomy. It's just really challenging to know what component of each specific symptom is due to parathyroid disease and what component is due to something else that they may have as part of their underlying conditions.
That's an excellent answer, Brenessa. I think that's something that we all face when we see patients and we don't want to give them a false sense that we're going to cure everything once their calcium normalizes, but there is hope that things will improve. So I think this is a great question for everyone in the panel, and we can address this from a medical or just even a practical standpoint. What are your recommendations for preparing for parathyroidectomy? So you've been diagnosed with it, you have met with surgeon, you're ready for surgery. What things should you be doing in order to get ready for a parathyroidectomy? Sophie, why don't we start with you?
It's fair. So depending, I would make sure that my vitamin D levels check and see where they're at. If they're low, I would start on a vitamin D supplement at least a week before surgery, because that can help. In the post-operative course, with having normal calcium levels. I would seek out a high volume endocrine surgeon, because that would be the best way to have the best outcomes from my surgery. What else would I do? I think those are the biggest things I would do. Vitamin D and a surgeon I could trust.
Yes, I agree completely. And I think Sophie hit on exactly the things I would recommend that are parathyroid specific. And the only things I would add would be things that you can do to prepare yourself for any type of operation. The majority of parathyroid operations are done utilizing general anesthesia. And so making sure that you are in the best physical health possible is ideal. Sometimes parathyroid patients have difficulties or limitations that may prevent them from adhering to a strict exercise regimen, but whatever you can do in terms of walking or ensuring that you are getting as much physical activity as you can. The American Heart Association recommends 150 minutes of moderate intensity aerobic activity a week. And so if you can do that, if you smoke or utilize other substances, that you cut those back. If you are more than a couple of weeks out from surgery, or quit smoking, that's probably the best thing that you can do for your health generally. If you have diabetes, trying to ensure that your blood glucose is controlled. Those are general facets of preparing for surgery, but those are things that have been shown over and over again to be beneficial for recovery.
Yeah, when I talk to my patients beforehand, I do emphasize the vitamin D and making sure they have adequate, as Sophie mentioned. The other thing I tend to tell patients, especially if I think they have relatively severe hyperparathyroidism, is to be prepared for hungry bone syndrome. I think the potential of the transient hypocalcemia and the hungry bone syndrome afterwards, because patients are sometimes shocked that all of a sudden they have to start taking a lot of calcium, and or sometimes you put them on an active vitamin D compound for a short period of time when they do have a hungry bone syndrome. Now, I don't know if we see that more commonly in people with kidney disease than without, but that's one thing I generally prepare my patients by discussing that.
Yeah, the only other thing I would say is if you're on cinacalcet, you would stop it, before the surgery. And then the other thing I'm wary of is if somebody is getting osteoporosis medication treatment with potent osteoporosis medicines like Prolia or Reclass, that may increase the risk for hypocalcemia. So I always am a little bit wary of how do I time it and how should I do that. So those are kind of important factors for some patients.
Yeah, and I think, at least in my practice, the hungry bone, I really see in those patients with secondary hyperparathyroidism who have renal failure and, may be in the hospital for a week after parathyroidectomy with a lot of calcium replacement due to hungry bone, as opposed to the patients with primary hyperparathyroidism, which are usually just outpatient surgery. And I think that's one of the things Sophie mentioned about going to a high volume surgeon. Typically would have a protocol to, put you on some calcium, measure your levels after the surgery, so you don't just go out and end up having symptoms and coming back to the emergency room, but having a plan to try to prevent that from happening by being on some calcium and maybe the active vitamin D. So Rob, you mentioned something that a lot of patients ask me about is what if they're on an osteoporosis medication and then they're going to have a parathyroidectomy? And of course, it's specific depending on the medication, but can you give us some thoughts about should patients continue medical treatment for osteoporosis, give a holiday?
Yeah, so I am a fan of if somebody has osteoporosis and they're going to have parathyroid surgery, I let the surgeons do the work without medications most of the time. We don't have any data, really good data, to know if it's better to do surgery plus osteoporosis medicine or just surgery alone. But I always give surgery time to work and then follow up with the bone density. Now, if they're on a medication for osteoporosis and they haven't had a lot of fractures or they don't have fractures, I may very well have them stop like an oral medication like alendronate, which is one of the common ones used. Prolia, though, is a whole different story because when you stop Prolia, it's going to lead to accelerated bone loss. And so that one, what I've done in that setting is sometimes I'll even transition them to an oral bisphosphonate or an IV bisphosphonate, depending on the patient and how long they've been on it. And then, the surgery might be done and after we think they're stable on that bisphosphonate if they want to stop it. Otherwise, if they're on the Prolia, they could have the surgery, but you might just be wary they'd be at higher risk, especially if the Prolia was given, right around the time of the surgery. Now, the other thing to remember is that Prolia increases parathyroid hormone quite dramatically. And so if you are measuring PTHs after surgery and they're on Prolia, that could be because of the Prolia, which is another problem. And, I'm sure Dr. Sprague wrings his hands over this as well. And in the kidney patients who are on it, you don't know what to do because these PTHs can go very high.
Yeah, actually, I'm glad you brought that up, Rob, because I was going to mention it. The issue with Prolia is problematic, and I really second the issue that you need to go to an experienced high volume endocrine surgeon, because I unfortunately had patients who've had parathyroidectomies that the hyperparathyroidism was secondary only to their Prolia and was not truly hyperparathyroidism. And that does create a whole problem. I, like you, if I have a patient that's on Prolia, I tend to put them on a bisphosphonate to get them off, and I will have them put the surgery off for 3 or 4 months. Again, these are rarely emergent surgeries, so I like to get them off the Prolia because that could really muck up things at the right time of the surgery.
Okay, great. We have another question from the audience. Are there any medication alternatives for treatments of hyperparathyroidism, both primary and secondary, rather than surgery? So I think we touched a little bit on the secondary, but how about for primary? We have the majority of the paratroopers have primary hyperparathyroidism. What other options do they have other than surgery at this point?
Well, I guess I can start. Obviously, one medication that we've talked about already is cinacalcet or Sensipar, which is a medication that stimulates that calcium sensing receptor, and through that, it actually can lower calcium quite effectively. Unfortunately, if you're taking it, you're likely to be on it for a long time, and that's the downside. And obviously, you'd rather have a curative surgery than put somebody on a long-term expensive medication with nausea. But we do use it. We might even use it after a kidney transplant where people have tertiary hyperparathyroidism to temporize that situation. It doesn't help bone density, though, and it really doesn't change PTH that much. Another medical option, honestly, would be if they have osteoporosis and their calcium's only mildly elevated and they don't want to have surgery, would be to use osteoporosis medicine to treat their osteoporosis. Now, if you use Prolia, which we just talked about, it can lower the calcium level to some extent. And so Reclast might a little bit as well, but Prolia could, but they clearly could help the fracture risk in that setting. And then, so those are really my main treatments. There's a couple of other tricks I'll do. I'd really be interested. Dr. Sprague is the kidney expert. If patients don't want to have surgery, but they have stones and high amounts of calcium in the urine, there's some data to say we could use thiazide diuretics in that setting to reduce stone risk. And as it turns out, they really don't increase calcium much in primary hyperparathyroidism, but they can lower PTH in some observational type of studies. So those are some of the things I've done, but I'd be interested in Dr. Sprague, I guess, what you do.
Yeah, no, I tend to use cinacalcet or Sensipar, as you said, and I'll do modified dosing like every other day as opposed to every day, which sometimes helps with some of the side effects in the long-term issue. Clearly, if I have a relatively older patient, someone in their 80s or something that has it, I tend to go that route rather than depending on what all their other medical situations are, to help control it. Thiazides do help lower, especially if someone's having stones. So it does tend to increase the serum calcium a little bit. It has really no effect on the parathyroid hormone level per se, in my experience that I've seen. But I think it depends where the patient is, what needs to be done. Most of the time, I try to encourage otherwise patients to have the surgery. I think in the hands of a good surgeon, and I've even sent people in their late 70s or whatever, depending, or 80s, depending on what their overall clinical situation is, that's much better because, again, it's usually done as an outpatient surgery and it's, in the hands of a good surgeon. The side effects or the risks, maybe they'll have problems with their voice for several weeks or a month or so after surgery. But, other than that, it's a pretty low risk procedure. You can really isolate, where the parathyroid. So I tend to try to encourage the patients to see me to do that. If not, I'll go with cinacalcet, and occasionally we'll use a bisphosphonate. I tend not to use Prolia in that situation, even though it will lower the calcium fairly well, just because I think it mucks it up, and then their risk of fracture, if that's to get stopped, is also increased. So I tend to avoid going with Prolia.
We'll
Okay.
say, I think
Go ahead,
most people can tolerate surgery. So I think it's really important for someone to have the conversation at least, even if, and just see what it entails and have that discussion about whether or not they could tolerate it. There have been situations where I've actually considered radio frequency ablation in like really severe secondary tertiary hyperparathyroidism for a patient who like might not be able to tolerate general anesthesia, or even to do at under regional anesthesia, where we numbate you up and don't put you all the way to sleep, do more of a twilight type of sedation. So there's a lot of other procedural tools that we have in our belts that we can kind of use at our disposal. If they're important.
It's interesting you mentioned radio ablation. We've also, depending on the patient, have used cryoablation, or radio ablation. I was afraid to bring it up in the crowd.
I know it's not
endocrine surgeons, but the biggest downside of that is if it's not successful,
right.
It makes it very difficult for a surgeon to go in and do it. So to me, it's a very, I do it, but it's a very unusual patient that I'll put.
It's hard too, because I don't know what the parathyroid hormone, when it drops and how it drops. And so it's hard for me to, but because I do it for thyroid nodules. So I've considered it in some patients, and we didn't end up having to go down that path, but it's definitely an option when it's needed.
Yeah, so maybe something, kind of more on the horizon, that there are maybe additional treatments that can be available that maybe haven't quite been validated yet in terms of how durable they are, but probably more information forthcoming. And Brenessa, can you talk about how successful parathyroidectomy is in terms of improving or curing even osteoporosis? Is it possible for surgery to actually reverse osteoporosis?
Yeah, I think Rob probably knows the data best about this, if I were guessing, given his line of expertise. But what I often tell my patients, which I think is probably the important framing for our conversation tonight, is that the most important thing is to stop the osteoporosis from getting worse. And so parathyroidectomy will help to halt the osteoporosis from getting worse. Whether or not it can fully reverse, I think is a little bit dependent on some other factors. And so I would love to hear the insights of other colleagues from the panel.
Yeah, I mean, there's no doubt that bone density improves when you do surgery. We just don't have good prospective fracture data to know for sure if it reduces fractures. There's some observational kind of studies, lower levels of science that suggest maybe it helps. I think though, bone density is a pretty good surrogate marker for fracture risk. So if we had a big enough prospective study that could be long enough in duration, which is a really hard study to do, it would show benefit in fracture would be I think it's very likely it would. But if I'm being completely honest tonight, I know it helps bone density, but I don't know for sure if you reduce fracture risk with surgery, but I think it probably does.
And we looked at this, Rob, in 2012 with Clive Grant, and the bone density improved in about 80% of people. Those that it didn't improve, it showed stability in their bone density, so they didn't lose any additional bone after surgery. Now, does that translate into a decrease in fracture risk is really the big question that we don't know for sure, because as the bone remodels after curing hyperparathyroidism, is it in the structurally the same way that it was prior, or is it as strong as the bone was before hyperparathyroidism? I think that's really the root of the question, is the ultimate goal of the bone density is to reduce the fracture risk down the road.
It's interesting because, Rob brings up a good point, but now I'm assuming they're doing it at the Mayo Clinic and some of these other centers, but with bone density, we're now doing trabecular bone score, which gives us a better idea of the quality of the bone. And I do believe, I don't have data, that parathyroidectomy in these patients probably will result in improving trabecular bone score. And trabecular bone score seems to be a much better predictor of fracture than overall bone density. So hopefully with time, we'll be able to get some of that information as well.
Right. So the point for our patients is that that's what we all really care about. You know, what you guys care about is what is your risk for fracture? The bone density is sort of a number, but the reason we care about it is really how does that correlate with the risk of fracture? And so it may not be this perfect correlation. Hopefully we'll have upcoming better data about how much parathyroidectomy can actually reduce the risk of fracture. And I just wanted to go back to this issue of the ablation of the parathyroid gland, because I'm getting some comments from colleagues that are watching. So again, just to kind of clarify for the audience, we really want to be up to date with all the tools that are available, and everybody might benefit differently from different options. So I think it's good for us to have more options that are available. I think right now there just hasn't been a lot of data yet about ablation for the parathyroid glands in terms of long-term effectiveness, but also the potential risks, especially like maybe that upper parathyroid gland that's close to the vocal cord nerve. Probably that would not be a standard treatment right now, but good to know that that option could be available if you go really to a specialized center.
I'd like to further comment. We've started doing them about 10 years ago. And we recently, we've not done a lot, but over 10 or 11 years, we've got about 55 patients. And we actually went back and looked at these patients. Over 50% of them had recurrent disease that required surgery. And the surgeons were not real happy going back in or going in there after they had ablation. Now, a lot of them were radioablation initially. Now, more recently, we've been doing cryoablation, or actually some of them were alcohol ablation initially. So I've been a lot less enthusiastic now. It would have been more, if we had a real positive study, we would put it out. We've been dragging our feet on putting an abstract together and writing it up. Our interventional radiologists are not real anxious about us writing it up, the ones who did the procedures. So I will tell you that we had over a 50% failure rate looking at these patients.
Thank you for sharing that experience with our group, and please do write that up because I think we're all kind of eager to know, when can we do these less invasive approaches for patients. There's another question from Facebook about, is anybody aware of hyperparathyroidism and any associated risk of cancer? I'm assuming we're not talking about the risk of parathyroid cancer, which we know is very low, but other types of cancer. And I will, go ahead, Rob.
Yeah, there is some data in patients with severe forms of parathyroid disease, severe primary parathyroidism, especially from Europe, where they have shown that or believe that they may have an increased risk for cardiovascular disease and cancers. I'll just say we just published our 45-year experience from Rochester, and we actually do not find any increased risk of mortality in a community population, except in people with more severe hypercalcemia. And as it turns out, the cutoff was about 10.8 and higher, where we saw an increased risk of death. And with surgery, we found the same cutoff. If your calcium was 10.8 or higher, you did surgery, mortality was reduced. Now, in regard to cancer, we looked at causes of death and we saw no increased risk of cancer, but we did see a signal for cardiovascular disease. So at least in the North American literature, with more mild, run-of-the-mill primary hyperparathyroidism in the US, where we screen more commonly, we didn't see a signal in our population. In Europe, there appears to be a signal for whatever reason.
So I guess I'll direct this to our endocrine surgeons in the group. So both the endocrinology team here and nephrologists, as well as the surgeons, have brought up the idea of high volume surgeons or an endocrine surgeon. Can you guys just elaborate a little bit for people who aren't in our group or have done a lot of research on this? What does that mean to be high volume, and what defines an endocrine surgeon these days?
So a high volume endocrine surgeon, it's really someone that's doing 25 to 30 cervical endocrine surgeries a year, so thyroids, parathyroids. And we know that the outcomes in terms of complication rates, hematoma, and then sometimes cure rate even for parathyroidectomy is it's better when someone has experience in that space. So someone being an endocrine surgeon, someone who's either gone through general surgery residency or ENT residency and then done an extra year of fellowship to focus on thyroid, parathyroid, and adrenal surgery. And then surgery of endocrine functioning tumors. Brenessa, do you have anything else to add?
I think you've covered it well, Sophie. The one thing that I would add that is maybe late breaking, and so I don't know if everyone on the panel will be familiar with it, but it is moving forward. And that is that the American Board of Surgery, in conjunction with the American Board of Otolaryngology, are offering a focused practice designation in head and neck endocrine surgery, so specifically for thyroid and parathyroid surgery. And there will be specific criteria related as Sophie outlined. So people that have completed specific training or that really devote a majority of their surgical practice to care of patients with endocrine surgical disease. So specifically for this, the thyroid and parathyroid glands. But as we think more broadly about endocrine surgeons that are members of our American Association of Endocrine Surgeons, those that care for disorders of the thyroid, parathyroid, adrenal, and neuroendocrine, pancreas, and other tissues throughout the body. And so that's going to define some minimum criteria with number of procedures per year that reflects back to some studies that have been performed, some systematic reviews that look at, surgeons that perform at least 40 of these operations per year tend to have, as Sophie had said, lower rates of complications and have just shown in general to have better outcomes. And so surgeons that meet that volume criteria will be eligible to apply for that focused practice designation through the ABS and will actually be required to undergo an additional certification mechanism on a repeated basis to sort of maintain that certification. So that's not available yet, but within the next 2 to 3 years, you should be able to seek out surgeons that, in addition to being members of the AAES and being able to ask your surgeon about what their own case volumes are, which is always a good idea, to be able to determine and see if they've gotten that focused practice designation.
Yeah, and I just wanted to make a comment about access to care. We have a lot of patients who are fortunate enough to be in the cities where, all of you practice, where we all practice and can see us. And then we have a lot of patients who are not in those areas and who don't have access to, an endocrinologist, endocrine surgeon that specializes in this area. And I think that's difficult when there is nobody in close to you that is doing, 25 or 40 of these operations per year. So I think my best advice in that scenario would be, one, go to whoever is doing the most of them. And there should at least, they should at least be doing some of those. They can talk to you about what their success rate is. And then really to do your best to make sure you have pretty good imaging. I think if you have a really clear, big parathyroid adenoma easily seen on imaging, it's likely that operation will be successful. And if that's not the case, to perhaps, just try, put in whatever resources, if it's possible, to go see somebody who is more experienced in high volume, particularly if your imaging has not been very definitive. And there's so many of us now that are doing telehealth and video visits that I feel like that has improved access to care to at least have that second kind of opinion.
That is such an important point, Masha. I'm sorry, Benzon. I just really want to emphasize that because that is exactly the practice that we see here in Alabama, right? So I have patients from all across the state, and the majority of my parathyroid practice are patients that have had negative imaging studies and have multi-gland disease. And it's wonderful that they are able to come to our tertiary referral center to seek out their care. We have many patients who have, 2 imaging studies. They show the same thing. It's localized. And those patients many of them are able to have a successful operation with surgeons that are in the community. And I think many of us that are members of the AAES or, other endocrine surgeons would often be happy to advise via a televisit if that's something that, you can't travel to the center themselves, or recommend colleagues that maybe aren't members of our organization, but that we know that do these operations frequently.
I think everyone makes a great point that it doesn't have to be AAES. It doesn't have to be you did an endocrine surgery fellowship, right? Because there's only 25 fellows every year. The fellowship's only been around for about 15 years, right? So in the United States, there's, I don't know, 500 fellows out there, which isn't enough to serve hundreds of millions of people. It's really the questions to ask are experience, volume, success rates. And I think as surgeons, we all love to get those questions because we know that the patient's done their homework, that they have, and that they really understand the disease and are making an informed decision with their own healthcare. So I really echo what everyone's point has been. So I think we're coming up to the top of the hour at this point. Does anyone want to make any last comments right now?
It's Stuart Sprague. I just want to comment again when we talked about medical alternatives in secondary hyperparathyroidism. I think what we also have to know is we always have, and we have the Endocrine Society, and every society has vitamin D thresholds of what levels we should have. Well, in fact, I've been involved in 2 publications. I think there's about 4 or 5 out there now that have shown people with chronic kidney disease need higher vitamin D concentrations than the normal population to regulate the parathyroid hormone. And that you actually may need to get vitamin D concentrations up to 60, 70, or 80, which sometimes makes other people nervous, but in someone with chronic kidney disease, that wouldn't be inappropriate. And the other thing is, in addition to using the standard nutritional vitamin D or the pro-hormone, there is a new drug called extended release calcifediol, which is a more activated form of vitamin D that only requires activation by the kidney to make it into that active 125 vitamin D, which has also been shown to be very effective at increasing vitamin D levels up to 60 to 90 in patients with chronic kidney disease, and causing our threshold is a 30% decrease in parathyroid hormone and able to cause that. So I think there are that therapy and others on the horizon that we could potentially use, at least in people with secondary hyperparathyroidism.
Great. So we would like to thank our viewers on that note and supporters for joining us this evening. A special thank you to our expert panelists for taking time out of their busy schedules to answer your questions and discuss primary and secondary hyperparathyroidism.
Yeah, thank you again so much. We're so fortunate to have panelists who are, working on the guidelines and doing the research that really informs these topics. So thank you everybody for taking the time, and Benson for moderating with me. As a reminder, the session was recorded, will be available on the AAES Facebook page and on the AAES YouTube channel. For more helpful information for patients, please be sure to visit the AES patient education website. And the website is going to be posted with a web address by our staff. Thank you so much for our AES staff also for helping us to put this webinar together. Have a good evening, everybody.